questions.
My lady. Dr. Crisp, before we move on from the critical care rapid guideline we were discussing before lunch, can I ask this? Are there any final points that you would like to share with the inquiry that you haven't already had the chance to?
Yes, thank you for the opportunity. It goes back to involvement in the targeted consultation on NG 159. You asked the question, did we involve the groups involved with people with learning disabilities and autism? And we didn't. However, we did engage with the clinical lead for critical care and with the Richmond group of charities who represent organisations for people with long-term conditions and complex needs. So it covers, for example, Mind, the Alzheimer's Society, Parkinson's UK, and the issue surrounding the clinical frailty scale was not raised with us during the consultation process.
I see. Is it right that in March 2021, this rapid guideline, and indeed all the other rapid guidelines NICE produced through 2020 to March 2021, were consolidated into what NICE called the Living Guideline, Managing COVID-19?
Yes, that's correct.
I'd like to ask you a question or two about whether NICE considered including within that Managing COVID-19 guideline a scoring system which the inquiry has heard some evidence about, called ISARIC 4C. I do so with the caveat that this is not something you have personally assessed in your capacity as you were then the director of the Centre for Guidelines, but that you have made the relevant inquiries within NICE so that you are able to assist the inquiry with the consideration that was given to that scoring system. Is that right?
Yes.
If we could please start by going to INQ 000 474255, thank you. This comes from the expert report the inquiry has received on intensive care. We read at the start of this paragraph, although ISARIC 4C is the best available numeric predictive score for COVID-19 outcomes, it is not in general clinical use, as despite the impressive rapidity of development, it was not published and available for use by the time of the first wave peak. That may well explain why it could not have been considered for inclusion in the early iterations of the rapid guideline, critical care in adults. It is right to set the scene, is it not, that ISARIC 4C was not included in any further iterations of the critical care rapid guideline, nor was it included in the Living Guidance Managing COVID-19.
That's right.
Can you help the inquiry then in this way? Whether NICE considered incorporating ISARIC 4C into either of those pieces of guidance, or indeed any other, and ultimately why the decision was made not to?
Yes, so we did look at it. It was identified through our continuous surveillance of the knowledge base as more knowledge and experience and expertise was developed as the pandemic continued. So we became aware of a number of scoring tools that were being developed. So in October 2020, we conducted a systematic review on risk prediction tools or models for admission to hospital or critical care to understand the broader evidence base. We found a large number of studies covering a variety of tools and models. And the conclusion at that time, so this was conducted between October and December 2020, the conclusion at the time was there were a variety of early warning scores being developed, and it wasn't possible to, at that time, determine that one was better than another and therefore should be recommended. So that's one aspect of it. It's particularly relevant to that particular tool. And also in December 2020, in step with the way that clinical care was developing, our focus moved away from individual rapid guidelines, as you've indicated, that looked at, for example, admission, moving more towards this consolidated guideline, which had more of a focus on management and therapeutics as we developed more knowledge about what management techniques and processes and interventions worked. So there were two answers to the question. Yes, we looked at it. It was one of many. There wasn't enough evidence to recommend it. And secondly, it was this shift away from tools and models for admission to more of a focus on management and therapeutics.
Can I take it then that the second part of your answer perhaps explains why further consideration wasn't given to it in 2021?
Again, I think if we were, and it is a living guideline, if more evidence and knowledge with that particular tool was developing, the team would look at that. And when we talked earlier about updating and reviewing guidelines, if there was enough evidence to suggest a change in a recommendation, so for example, to recommend ISARIC or indeed any other scoring tool, we would consider that and consider whether it warranted a partial update or a refreshing of the recommendations.
Can we turn finally then, Dr. Crisp, to lessons and recommendations? Can I start with this? In the event of a future pandemic, is NICE in a better position to create rapid guidelines? And if so, how?
I believe it is. Two aspects to that. One was in July 2020, after we'd produced 21 guidelines in 3 months, very rapidly, during that time, we were continually looking at what worked well and what we could do better. And we summarised that in an interim process and methods guide in July 2020, which, if you like, codified a future approach. So if you recall when we spoke earlier, the first 3 guidelines were produced in 5 working days. So NICE had taken that decision to move quickly and condense and compact many of its normal processes. As we progressed through those first guidelines, we learnt that there were some areas that we could actually move back towards a more normal process. So could it work? Could it do that better in the future? Yes, we could. And those new ways of working, those methods and processes, we published in July 2020. And in particular, I want to go back to the equality impact assessment that we spoke about earlier. We would take a different approach to a future scenario. We have a greater awareness of the need to involve a wider stakeholder group, as we would do normally on a guideline. So that interim process and methods guide for producing guidelines in response to a pandemic the equality impact assessment element of that has not been condensed. It's the same as it would be in a regular standard guideline. So that's one learning. And then the second one is a deeper, more thorough, systematic approach that the organisation took in 2022, where the executive team looked at an organisational lessons learned. So not just guidelines, but what else can we learn? So the more flexible, agile methods and processes and the prioritisation based on what would have the greatest impact on user needs are now built into the way we work, the way the organisation works. And that further strengthening and signposting of efforts to address health inequalities has been taken to heart.
Those are key lessons that NICE has learnt and acted upon. Perhaps looking forward, are there any further recommendations that you would like the inquiry to consider?
I think the main one would be when I reflect back to March 2020, NICE had a position in the health system as producing guidelines, and everybody understood what that meant and what a guideline was, and it would take 12 to 24 months. When we were asked to rapidly pivot and produce guidelines within often 5 working days to 14 working days, I think we could have been more prepared had we been more involved in the emergency response infrastructure, if you will. And again, one of the lessons learned that we've put into practice is that our Chief Medical Officer is now part of the National Emergency Preparedness, Resilience and Response Clinical Reference Group, which is good. And it's acting more as a system, I think, as early as possible. And I think the product would have been better and the advice and guidance we gave would have been better.
Dr. Crisp, thank you. My lady, that's all I ask.
Thank you very much. Mr. Boer, behind the pillar, that you can see him.
Thank you.
Good afternoon, Dr. Crisp.
Good afternoon.
I ask questions on behalf of COVID bereaved families for Justice Cymru, who are a group of bereaved families in Wales. And the members of the group are particularly concerned about the inconsistent application of DNA CPR policies. So my first question is in relation to the guidelines that we've already looked at, the NG 159 guidelines. Upon reflection, do you accept or would you like to comment on as to whether the guidelines themselves gave clinicians too wide a discretion to make DNA CPR decisions without taking into account the wishes and feelings of the patient and or their family, and or failed to refer the reader to local policies that were in place?
So the intent of the guideline was to support normal ethical decision making, and that shouldn't have changed due to COVID-19. We expected clinicians still to exercise their clinical judgment and in consultation with patients, their carers and families. So I think you asked the question, too much discretion. I would say that discretion is part of reaching a DNA CPR. It should be individualised. It should be person-centred.
Okay, thank you. And do you think that NICE could or should develop a DNA CPR quality standards guideline with significant contribution of patient care involvement so that a uniform standard can be adopted in the UK and effectively end, and so that end-of-life care is less a postcode lottery? And if so, what challenges would that task pose?
So As I mentioned earlier, topics are referred to NICE through NHS England and the Department of Health and Social Care, and they are then assessed by a prioritisation panel within NICE, and which guidelines are taken forward depends on a number of factors, including whether the guidance is within NICE's remit, whether there's a gap in the portfolio or significant unwarranted variation. I think the answer to your question would primarily fall within, does it fall within NICE's remit? And to that, I would say that NICE doesn't normally produce guidance on professional standards or conduct, but I think any topic should be looked at through that prioritisation lens, and that's how NICE would make that decision, should it be referred to the organisation.
Thank you, Dr. Crisp. Those were the questions I have.
Thank you, Mr. Brewer. Mr. Weatherby.
Just one very discreet and short topic from me on behalf of COVID Bereaved Families for Justice UK, Dr. Crisp. In April 2020, NICE issued guidance with respect to target oxygen saturation levels and with respect to the range for the most acutely ill patients. And it reduced the target saturation level from 94 to 98%, which was the standard pre-pandemic. First of all, down to 92 to 96%, and then down to 90 to 94%. And that was because of a shortage of oxygen, wasn't it?
So that particular piece of guidance that you're referring to was an NHS England piece of guidance that was published on the NICE website. So it wasn't a NICE piece of guidance.
Right. Okay. I mean, you refer to it in your table 4 at page 59 to 60. But is my question, is it right? Or if you don't know, obviously say you don't know. But
I don't know. I'm sorry.
I shan't ask you any more then. Except for, do you know that the guidance then went back up to the pre-pandemic level or not?
I don't. I'm sorry. I don't know.
Thank you very much.
Apologies.
Thank you, Mr. Weatherby. Ms. Hannett, over that way.
Dr. Crisp, I asked questions on behalf of the long COVID groups. Can I ask you first, please, about the development of the guidelines on management of long-term symptoms of COVID-19, the long COVID guidance? Do you agree that there was time lost in starting to prepare guidelines between July 2020, when SIGN first proposed the idea to NICE, and October 2020, when NICE agreed to work with SIGN and RCGP on the guidelines, since treating clinicians were dependent on the guidelines to inform their response to COVID-19?
So to produce a guideline, we wait for a referral from NHS England or the Department of Health and Social Care, and the referral came in on the 30th of September. So if we'd have received it earlier, we would have started earlier.
Thank you. And I was going to ask you about long COVID in children and young people. And there were no guidelines issued for long COVID in children in December 2020 when the NICE guidelines were first published. And it wasn't until November 2021 that the NICE guidelines were reviewed with evidence on children and young people. Again, do you agree that there ought to have been some information on care and support for children and young people earlier than November 2021?
So I think the scope, I know the scope included children and young people in the update that you refer to, November 2021. And had there been information in the first version, I think we would have included it as well. I'm sorry, I can't recall if children and young people were included in the scope of the first guideline we produced in December 2020.
Is it right then that you weren't then asked to review it until November, there was no. Why were they not then included in the revisions? Whether it was included in the scope originally, why were they then not included in the revisions between December 2020 and November 2021?
So we conducted a review in November 2021. That was the first opportunity we had to do a complete review of the guideline. And that included symptoms, referral, and management, because there have been a lot of new experience and evidence from people suffering from these awful, debilitating symptoms.
And were you not asked to do a review before then?
No.
Can I just ask you then about post-exertional malaise in the guidelines?
Before you do, Ms. Helen, could you make sure, Dr. Chris, that your answers go into the microphone? I'm sorry. No, that's all right. It's easily done to look towards the question.
Sorry, Dr. Crisp, I'm not ideally located to ask you questions. Would you agree with Professor Brightling and Professor Evans, who gave evidence yesterday that clinicians would now be assisted with clear advice on post-exertional symptom exacerbation, the guidelines on treating long-term symptoms of COVID-19?
I think there's a research recommendation in the guideline for what's the clinical effectiveness of exercise interventions. So the long COVID guideline is under continual surveillance, and as evidence and the knowledge base increases, there is always a point where there might be a trigger to update the recommendations we make. So, as I said, the guideline has research recommendations, because we were unable to make them in November 2021, around the clinical effectiveness of exercise and whether exercise rehabilitation assists in improving symptoms. So there may be evidence and knowledge on that which may be able to trigger an update. But again, I'm not familiar with that. I'm not close to the subject. But if there was, that could be taken into account in an update of the guideline.
And can you, just on follow-up question on
Sure.
that, can you explain why there hasn't been any substantive update to the guidelines since November 2021? You just described there's been quite a lot of knowledge and expertise that's developed since then, and yet there's been no revision since November 2021. Can you help the inquiry with why that is?
Yeah, I'll try. So NICE has a portfolio of, I think, about 350 guidelines, all of which need to be kept up to date, as well as new topics coming in. And the decisions to produce new guidance or update whole guidelines or sections of guidelines is taken through this prioritisation panel that makes a decision on where we should be placing our resources as to which guideline to update on what sort of timeline. So it is one guideline amongst many that NICE needs to consider where it prioritises its efforts to update depending on need, the variation in care, impact on people, and impact on the quality of the care they're receiving.
Can I just ask you, though, what about the living guidelines, though, Dr. Crisp, that are meant to be consistently updated, and why hasn't that process been applied to the long COVID guidelines?
So again, it's a case of whether or not the team has found the evidence to trigger an update, and I'm surmising that they feel that they haven't.
But you don't know?
I don't know. I've been out of the organisation for several months now.
Thank you, Melanie. Thank you, Dr. Crisp.
Thank you, Ms. Hurt. I think that concludes all the questions for you, Dr. Chris. Let me just check.
That's right, my lady.
It does. Thank you very much for coming out of retirement to help, and I'm very grateful for your assistance and for your frankness where you thought something may have gone wrong, and for being open with the inquiry. Thank you.
Thank you.
Ms. Carey.
Lady, the next witness is Professor Helen Snooks.
Yes. No. Thank you. Just repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
nothing but the truth.
Professor, I see you're still suffering.
Yes.
I hope your recovery is continuing.
Yes, thank you.
Thank you.
Professor Snooks, your full name, please.
Helen Ann Snooks.
Right, I think you've got a copy of your expert report in front of you, ending 474285. But I suspect it might be easier to put on screen any passages that we need to
Thank
look
you.
at to save you rifling through it.
Thank you.
A little about you. You are a Professor of Health Services Research with over 30 years' experience in the fields of emergency and unscheduled care, and particularly experience in emergency pre-hospital care. You are primarily a methodologist, and is this right? You're not a clinician.
That's right.
You haven't worked for an ambulance service.
I have worked for an ambulance
Have.
service. So I have worked between universities and the ambulance service. And in the 1990s, I was based at the London Ambulance Service and employed by the London Ambulance Service as clinical audit and research manager from 1995 to 1999.
Thank you very much for clarifying that. You are a researcher, though, and you have been the editor for the National Institute for Health and Care Research for over 10 years and have recently taken on the role of senior editor for the National Institute for Health and Care Research.
Yes.
You were instructed by the inquiry to look at two different matters, emergency pre-hospital care and the efficacy otherwise of the shielding programme. And I'd like to concentrate on the former for this reason, Professor. Since you were unable to join us a few weeks ago, we've heard a lot of evidence about shielding, so I'm hoping I can take that a little more quickly than otherwise I would have done. All right. Can we start, please, then, with pre-hospital care? And I think you set out in your report that calls to 999 are categorised by their urgency. And am I right in thinking that in England and Northern Ireland, there are categories 1 to 4, and in Scotland and Wales, they are colour-coded, but essentially 4 colour schemes. All of them in common have the most life-threatening and serious as their first category, if I can put it like that. And all of them have at the bottom end, perhaps the less urgent category, those who've tripped over or have got vomiting, matters like that. All right.
Yeah.
Now, I'm not going to go through the precise niceties of each of the different categorisations, but one can understand the need to categorise the calls depending on how urgent the call is.
Yes, in order to provide a speedy response to the most urgent calls and to provide a slower response, not such a speedy response to those that don't require it.
Yeah. And I think the category of the call then determines the response time target, and each of those vary by nation, and each of those vary by category.
Yes.
All right. Now, that is all set out in the report. If people want to descend to the detail, we may touch on 1 or 2 response times
Yes.
as we go through your evidence. Can I ask you, please, though, about clinical decision support software and the systems that are used across the UK ambulance services?
So just before you do, I'm terribly sorry, I meant to ask a question. In relation to the categorisation, so if you get categorised as 1, obviously your top priority. If you get categorised as 2, and I confess here I'm speaking from personal experience, does it make any difference to your categorisation, even if you wait for hours, because more Category 1 calls have come in?
No, it doesn't make any difference. If you called back, your categorisation could change because your symptoms may have worsened, so you could actually be put into a higher category. But no, it doesn't change from what you said. You're in that category until the ambulance is available to come to you. And as Jack said, Ms. Carey said, there are response time targets associated with each category, but they're not always met.
I was going to say that's what maybe asked the question about whether if your time target hadn't been met, that would make any difference to your categorisation, but not unless your symptoms worsen. Thank you. Sorry to interrupt.
No, not at all. The different pathways that are used by the ambulance services, there are two. One is known as the Advanced Medical Priority Dispatch System, or AMPDS, and the other one is NHS Pathways. But can you just give us an overview of what those pathways are designed to achieve?
So these are they're the computerised software used by the call takers, so the people that answer the 999 calls, to assign those priority categories. And they go through a set of questions, which they are slightly different. So AMPDS is more structured than NHS Pathways, but they are aiming to do the same thing, to find a way to put people into the appropriate category for their need.
So, for example, you might be asked straight away, is the patient breathing? That's a pretty clear indication of how severe or otherwise. And then the pathways will depend on which one is being used and the questions that are asked to elicit the right response.
Yes.
Right, understood. I think pre-pandemic, was there any evidence being conducted of how accurate or otherwise those two pathways were?
There has been some research published over the last, I would say, 20 or 30 years, but there wasn't an awful lot of recent evidence. And I wouldn't say it was definitive, but a lot of ambulance services have been carrying out their own audits and quality improvement exercises because they have not all selected the same system. So there's been quite a lot of work going on to understand, and there's a completely different financial cost. So the AMPDS is a commercial a company that's paid for, a contract for that, whereas NHS Pathways has been derived from within the NHS in the UK.
Do you know whether there was any evidence conducted into those pathways as to whether the algorithms might have produced unequal results for patients?
I'm not aware of that.
So one can't say, well, AMPDS is better at diagnosing this and you get a better response time with that pathway as opposed to NHS pathways?
No, and that I don't think ambulance services would have been choosing both if that were the case. Yeah. So they've really been choosing both based on other factors.
Now, your report sets out at paragraph 9 the process for accessing emergency care in business as usual, so pre-pandemic times. And I won't go through the various steps, but in short, obviously, if you ring 999, you go through to an emergency operations centre, then the call handler takes you through the questions to determine how urgent the response is, and then the call gets processed to a dispatcher, is that correct?
Yes, each ambulance service also has usually a clinical desk, so if further advice is required, the call taker, the call handler, who is non-clinical, can pass it over for clinical advice. This existed even pre-pandemic. And then, yes, it gets sent on to a dispatcher to operationalise the response from the ambulance or whatever.
Right. And then the ambulance gets dispatched and attends the scene or the home or wherever it may be. Ordinarily, is this the position that an ambulance will have 2 crew members, usually 1 paramedic who's educated to degree level, and indeed 1 emergency medical technician who's done a slightly shorter period of training?
Yeah, that's the ideal. It doesn't always happen that way. Sometimes you might get 2 EMTs, the more basic level crew, together, and sometimes you might get 2 paramedics, but ideally there's 1 paramedic and 1 EMT.
Right.
But I would just say that not every call will receive the dispatch of an ambulance. Some calls will end with the 999 call with other advice, self-care advice, or
see a GP.
No send, yes.
Yeah, understood. and then the ambulance crew attends, decision is made with the patient about whether to convey the patient to hospital, and then depending on how urgent it is, various notifications go through to the hospital.
Yes.
Okay. Can I ask you about the metrics, or the performance metrics as they're called, for ambulance response times, and your paragraph 10. And perhaps if we could call up on screen, please, 474285 underscore 8 and 9. I think people will see now why we haven't descended to the detail of all of the different categories. But I just want to pick the most serious category for each of the nations so we can understand where we were pre-pandemic. In England, is this right, since 2018, if the call to 999 is categorised as 1, being life-threatening, so someone's had a cardiac or respiratory arrest, target response time is 7 minutes. Is that 7 minutes to the ambulance arriving at the patient?
Yeah, from the call to arrival at the patient, and that's on average.
Right. And 90% of the calls must be responded to within 15 minutes.
Yes.
That gives us an indication of how truly life-threatening Category 1 calls
Yes.
are. And I think in Northern Ireland, if we just go down to paragraph 12, please. Similar, Category 1 in Northern Ireland, response time there is 8 minutes.
Yes.
In Scotland, their most serious category, I think, is purple. Is that correct?
I believe so.
And if we look at page 9, it's some bullet points on page 9. Thank you very much. In Scotland, the purple category are based on the median times, 6 minutes there, and 90% of the calls have to be responded to in 15 minutes.
95% it says.
Sorry, what did I say? Yes, 95%. Thank you, not 90. And finally, in Wales, red calls, they're called in Wales, set response standard. 65% of the calls are expected to have an emergency response within 8 minutes. So I think it's 6 to 8 minutes, roughly,
Yes.
depending where you are in the UK,
Yes.
for an urgent call.
Yes.
All right. Now, I set that as a base so we can see then what happened potentially during the pandemic. That's clearly if you're calling 999. Can I ask you about 111, please? And are you able to help us? What is the purpose of 111 services?
The purpose of 111 is to provide healthcare advice and information to anybody for free by telephone. They also provide online services.
Is it for non-urgent calls, urgent calls, everything and anything in between?
Everything and anything, yeah.
Right, okay. And I think there is 111 in England and Wales, and during the pandemic it was rolled out in Northern Ireland, is that correct?
I believe so, yes.
And in Scotland it is operated by someone called NHS 24.
NHS 24 is the service, and it's operated by I'm not sure, but it's not the ambulance service. Whereas 111 services are often, not always, often operated by ambulance services in England, Wales and Northern Ireland.
Right, but if I understand it correctly, certainly by the time we were in the pandemic, all 4 nations were operating not only 999, but a 111 type
Yes.
service.
Yes.
All right. Okay. And 111, is that a service that also relies on algorithms to talk through the level of care and the kind of advice that might needed to be given to the patient?
Yes, absolutely.
And in 111, again, is the call handler not clinically qualified, but where necessary, the caller can get a call back from a nurse or a paramedic?
My understanding is that varies between service. And I know in the past I'm not familiar with the current situation. In the past, there have certainly been some services which have provided that call-taking facility with a clinically trained call handler. So it has varied by service.
But generally speaking, 2 different ways now. People can ring if it's really urgent, or ring 111 if there may be some doubt in their mind about how urgent. But I think you make this point. If you ring 111 and it's urgent, you can be transferred to 999.
Yes.
Understood.
And sometimes they're in the same room,
Okay.
literally.
you make the observation that you have less direct expertise and knowledge of preparedness, but based on your research, the preparedness for 999 and 111 service prior to the pandemic had predominantly been placed around major incidents as opposed to a nationwide pandemic. Is that right?
That's my understanding, but I haven't done direct research of my own in that area.
Now, I'd like to ask you, please, about what is called Protocol 36. And can you help us in layman's terms, if I may put it like that? What was Protocol 36?
So Protocol 36 was a specific protocol that was added in or brought into use within the pandemic to assess calls of patients with suspected COVID infection. So it was noted very early on in the pandemic that the generic priority dispatch system, AMPDS particularly, did not have a specific protocol for dealing with the pandemic situation. There was that protocol available, but it wasn't in regular use. So it was brought in and introduced in, I believe, early April 2020. Yes. That was to services that used AMPDS, and NHS services that used NHS Pathways, the other priority dispatch system, developed their own tailored protocol for responding to suspected COVID-19 calls.
So this was to really try and help the ambulance services work out who did or may have COVID-19?
It was in order to assess their need for the response to that. So it was a specific way of asking questions to callers with with symptoms that might be COVID-19 to assess those specific symptoms in terms of their need for an emergency response, which it was felt that the generic system wasn't able to do, was under not taking enough account of specific symptoms that were coming up in COVID-19.
Well, I suppose, can I perhaps put it another way? If someone is ringing up saying they've got a cough, they've got a fever, they've lost their sense of smell or sense of taste, it might be difficult for the ambulance service to work out how serious or otherwise the symptoms are. And was Protocol 36 designed to try and work out this person might have COVID and might need to go to hospital?
Yes, it was precisely to understand in the context of COVID-19 when the need for the emergency response, what priority should that patient be given in a specific circumstance.
And I think you say in your report that in fact this protocol had been around since, was developed in the time of swine flu and was brought back into play during the COVID pandemic.
It's sometimes called Card 36, if you see that.
Now, can I just ask you the sort of bald question? Given that its aim was to work out if you had COVID and if so, if you needed an emergency response, in general terms, are you able to say whether Protocol 36 actually achieved its aim?
So I don't think it was to work out if the patient had COVID-19. It was to understand if they thought they might have COVID-19, what was the response required. How well it performed that function does come up in other parts of the report through research that was carried out.
Are you able to give us an overview before perhaps we descend to some of the detail?
Yes, yeah. So overall, I think I just need to say that triage or sorting patients out and the priority of patients is absolutely key to the provision of care to patients in an emergency. And it might be easy to think, well, why not just send the highest response to everybody? But that carries its own risks. So it's very important to not over-respond to people because that puts the whole system under pressure, as well as if the patient, for instance, has COVID-19 but does not need emergency transportation to hospital, then it's exposing more people to the risk of transmission and the ambulance crew as well. So I just wanted to preface that because I think people might think, well, why not just send the top response to everybody? But that's risky in its own way. So it's very important to not over-respond or under-respond and to try to sort out which patients are needing this highest level of response. That inevitably means that whilst trying to not over-respond, sometimes the services will under-respond. The research shows that those using card protocol 36, those instances of under-response when the patient wasn't given enough priority were relatively rare. They did happen, but they were relatively rare. But this was kind of at the cost of over-response to quite a lot of patients.
Well, we might look at some of the detail, but that just gives us a sort of overview of what it was aimed to do and the pros and cons, if I may put it
Yes.
colloquially, of what the service is trying to achieve.
Yes.
Can I ask you, before we look at that, about some trends in 111 and 999 use during the pandemic? And I think you and a number of your colleagues conducted a survey of all the UK ambulance services and received data from 12 of the 13 ambulance services.
Yeah.
And what was the aim of the survey that you were conducting, which I think you did from February to June 2020?
We wanted to gain a snapshot picture of what was the volume of demand, what was the pressure on ambulance services overall, and also in terms of COVID-related calls, and what was the effect on their response times. And also we asked all the services about what changes that they implemented during that period. So it was partly about providing us with statistics which weren't routinely available, and it was partly about asking them, well, what happened in the control room and how did you change practice during that period?
12 of the 13 ambulance services across the UK responded. It was Northern Ireland that did not reply, as I understand it. So you just don't know whether they had the data and didn't give it to you, or they just didn't have a chance to get round to replying to you.
Yeah.
But can we have a look at the call volumes? I think you say that the highest proportions of suspected COVID-19 calls were all recorded in the weeks of the 23rd or 30th of March. We went into lockdown on the 23rd. And then we get the calls here on screen identified as suspected COVID-19 by the ambulance services. And you haven't named them, but you can see the 12 and they're given different colours and lines. But if we look at, along the bottom, at around the 23rd of March, 30th of March, 6th of April, and we track up, and it may be that our evidence handler can add an arrow, but you can see going up the page a huge spike, certainly for ambulance service 3, thank you, from receiving where we were a relatively low number of calls in February up to nearly 20,000 calls in the 23rd and 30th of March.
Yeah, I think it's obvious from here that the peaks of demand in terms of COVID-related calls did not hit each ambulance service at the same time. So whilst there is that overall generalised spike there, and I think ambulance service 3 is here in London, but there were other services where the peak hit a bit later, and there were some services which were not affected by that massive peak in the same way. So it was very different between services and over time, reflecting the transmission, the spread of the pandemic across the country at that time.
Acknowledging all of those comments, though, clearly a huge jump if one takes ambulance service 3 there. And do you know whether there were sufficient call handlers to be able to deal with spikes like that? Has there been any research done to understand whether we were ready for it, if I can put it that way?
At that point, I'd say no, not for a huge change like that. I mean, that was like New Year's Eve every day. And so the London Ambulance Service put into place the New Year's Eve protocol of when to send, when to not send, and calling back to tell people there was not an ambulance available. So, but that was more extreme than anywhere else. There were definitely shortages of call handlers at the point, yes.
And this is calls to 999?
This is 999 calls, and it's just the COVID-19, suspected COVID-19 calls.
Right. Looking at 111, I think you make the point in your report that from February 2020, the public were encouraged to ring 111 as their first point of contact. And so I just want to bear that in mind when we look at what happened with the calls in relation to that. But I think you said there were huge increases in 111 demand. In England, and if we could have up on screen page 17 and figure 4, this is the number of calls to 111 that were either abandoned, answered within 60 seconds, or answered in over 60 seconds. And it's in the millions down the left-hand side of the graph. So we can see as we start very early on, 2014, roughly relatively stable numbers. And then if we go to the huge spike there in March, April 2020, there was, I think, 1.5 million calls in January 2020, and it spikes to just over 2.5 million calls going to 111 in March 2020. And is this right? Over 1.1 million of those calls were abandoned.
Yes.
And only 30% were answered in 60 seconds.
Yeah.
So having told the public to ring 111 as their first point of contact,
Yeah.
1.1 million out of over 2.5 million were abandoned at some stage during the call. I think you say there was a similar pattern in Wales to that demonstrated in England. And although not quite the same data in Scotland, could we call up on screen INQ 474258_33? NHS 24 did provide some data. It's not quite in the same format, but if we see there, these are the calls offered, calls answered, and the average time to answer. Beginning of March 2020, 8,157 calls, 6,249 of which were answered, average time in about 10 seconds. And if we go down to the 23rd of March, up to 12,000 calls, only 3,324 of which were answered, and it's gone from being answered in 10 seconds to an average answer time of 1 hour, 11 minutes and 34 seconds. So significant pressures on 111.
Yes.
I think, can I just deal with Northern Ireland? Did you have the data for 111 in Northern Ireland?
I don't think we did. Is it not in the report?
No, it's not.
Yeah, no, we weren't able to retrieve that. Could I just say that we were only, for this report, only accessing data that was already in the public domain.
Yeah.
So we weren't doing any sort of new request for data. So if we couldn't find it, it wasn't, we haven't reported it.
Can I stick with 999 and 111 calls, having looked at the various peaks of them, and just try and understand the impact that the peaks were having on the quality and the safety of 999 and 111 calls during the pandemic? And perhaps we'll deal with that as a section and then come back to some other matters. If it helps you, can we call up on screen page 22 of 474285? And I'd like your help, Professor, with this section of your report. You've explained why triage is important. And I think you set out here that there was a study. It was originally designed after the flu pandemic, but was hibernated. And so therefore woken up during March 2020. All right. Help us with what the Priest study was set out to analyse, please.
So the Priest study was looking at both calls to 999 and the 111 services that were categorised as potentially or suspect COVID-19. and was able to link those calls to outcomes to find out what was the accuracy of prioritisation, really, in terms of dispatch of an ambulance or a conveyance to hospital for the 999, and for 111, the advice that was given, whether it was self-care advice or whether it was advice to seek further care, to understand the accuracy of those categorisations, whether they were working well.
Now, I think it's just analysing data from one ambulance service. Is that
Yes,
correct?
it's from the Yorkshire Ambulance Service, and it's for a fairly restricted period of time in between April and June 2020.
All right. Even with that caveat to one side, one can see there that they're still analysing quite a lot of data from 40,261 adults who contacted in that ambulance service alone in that period of time, 111. There was over 12,500 that rang 999, and over 7,500 adults that went by an emergency ambulance. So,
And these have all been categorised as suspected COVID-19 cases. This is not the whole workload of these services.
no, this is just focusing on suspected COVID-19. So if you rang up because you'd had a heart attack, you're not going to be included in this data. All right, understood. Thank you. Now, can I ask you about your paragraph 61, which looks at NHS 111? Help us there. The risk of an adverse outcome, where you refer to that, you mean where the patient died or needed major organ support?
Yeah, this is the definition used in this paper. Well, there's two papers, one for 999 and one for 111, but they used the same definition.
And so where it says the risk of adverse outcome was 3% in adults calling NHS 111, what does that actually mean in lay terms?
So it means 3% of people that called 111 and were categorised as having suspected COVID-19 ended up at 30 days having died or needed major organ support.
Follows, if I follow you, then 11% of the adults that rang 999 either died or needed major organ support, and 17.6% of those who were taken to hospital by ambulance either died or needed major organ support. They're just the bare facts, if I can put it like that. But what does it actually tell us about how 111 and 999 was operating and how safe or otherwise it was?
Well, very broadly, there's an indication that there's some kind of appropriate triage going on there, that although there were adverse outcomes for people that had called 111, they were at a lower rate than people that had called 999. And then in terms of the 999 response, that there was it was a higher rate again of people that were taken to hospital by ambulance, had these adverse outcomes. So in very broad terms, that is reassuring.
Looking perhaps at the detail of paragraph 62, which focuses on 111, is it most patients who contacted 111 were given either recommendations for self-care or seek a non-urgent assessment, and the adverse outcomes were, I say only, I don't mean it like that, but were 1.3% of people who rang 111 died or needed major organ support.
Sorry, it's 1.3% of people that were recommended self-care or to seek a non-urgent assessment.
Right.
So 60% of patients that contacted 111 were recommended self-care or a non-urgent assessment. In other words, not referred to the ambulance service or told to go to the emergency department. And of that 60%, 1.3% had an adverse outcome, meaning death or requiring organ support at 30 days.
Right. Are you able to help us with whether that is a tolerably acceptable percentage of an adverse outcome or not?
I think it's a judgment call. It's a small proportion, but it's a significant proportion and an important proportion. Whether that is inevitable is another question. Could triage have been better? Maybe. but maybe not. This is not a question that I can answer directly. This would be, you might get a different answer from a different person, because it's a judgment call. And it's also what is achievable in this circumstance. So this is not really about whether the speed of response of the ambulance service or whether this is about the decision made using the algorithm, the computer decision support, as to whether the person, what did that person need. And of those that were told they could look after themselves, and usually it says call back if symptoms worsen,
Yep.
but of those that were given that advice, then a small proportion did unfortunately have a very poor outcome.
Yeah. And then it'll be for others to judge whether that's a good outcome, a bad outcome, one that we accept or one we think is totally unacceptable. All right. So that's if you rang 111, were recommended self-care or not to seek urgent assessment, there was a 1.3% of a risk of adverse outcome. If we go to paragraph 63, I think this looks at those that contacted 999, and you say that most patients in this study that contacted 999 received an emergency response, 84% it was. Patients contacting 999 who did not receive an emergency response, so 16% didn't receive an emergency response, had a 3.5% risk of an adverse outcome. And again, I'm presuming your same answer as to whether that's a good outcome, bad outcome.
Yeah, I just want to explain that receiving an emergency response means essentially being sent an ambulance or some kind of face-to-face. Could be a motorbike, or, but a face-to-face response for assessment face-to-face. And yes, there's a slightly higher risk here of an adverse outcome for those that actually did not receive an emergency response, and that might have been for many reasons that they did not receive an emergency response, and it may have been, in this case, a lack of a response to send.
Right.
But that also may indicate people that called 999 were maybe sicker than people that were calling 111, which is what you would expect.
I was going to say, does it seem out of kilter with the figures of an adverse outcome that we looked at for 111 services?
No, it feels again what you would expect.
And then paragraph 64, most patients, 65%, who were attended by an ambulance were taken to hospital. Of those that were not taken, they had a 7.9% risk of an adverse outcome. So higher again for those that didn't go to hospital. Again, does that strike you as being out of what you would have otherwise expected for those patients that rang 999 but decided for whatever reason not to go to hospital?
Yes, that's actually a bit more concerning, I would say, because they've had a face-to-face response from probably a paramedic, and then the decision has been taken not to take them to hospital, and they are at higher risk of an adverse outcome. So one would have hoped that would be lower, I think.
Are you able to opine as to what the reasons might be for why people were not taken to hospital, given that we know they had an ambulance response?
Yeah. So earlier on you did say that it's a joint decision, and to some extent it's a joint decision, but I think patients usually will go with the advice of the ambulance crew, but they could refuse. So the patient could have refused. The ambulance crew may have advised them that they didn't need to go to hospital, or that there are a lot of patients queuing outside hospitals in ambulances as well at this time. So that I can't really comment on which of those was happening, but you would like to see a lower rate of that. But it also could be that people deteriorated later. So at the point that decision, because this is a 30-day outcome, so at the point that they were seen by the ambulance crew, maybe they didn't need to go to hospital. Maybe a week later they needed to. Yeah. So it's easy to jump to conclusions, I think, but actually it's very complex.
Yeah, there's a number of reasons why it may be that on that given day they weren't taken to hospital.
Yes.
Yeah.
And they may not have needed to. I think that's important because people's symptoms were varying, and people did deteriorate very quickly during the pandemic. So it might have been entirely appropriate on the day.
Can I ask you about your paragraph 67, which is about some research undertaken during the pandemic, which I identified that 111 triage may have overestimated the importance of chronic lung disease as predictors of adverse outcomes and underestimated the importance of diabetes and repeated calls to the services as predictors of adverse outcome. A little bit of a mouthful there. But can you help us, Professor, with what was the concern you were trying to bring to our attention here in this paragraph?
So this is the same study, the PRIEST study, and this is 111 calls. And in addition to looking at how well did the call outcome, whether it's self-care advice, referral to 999 or whatever, how well did that match with then what happened to the patient? They looked at that and they looked at, well, what factors were involved in that, and what factors influenced the outcomes. So, and they found that that in the decision making, that some factors were given too much priority and other factors were under considered. So, for instance, diabetes and more than one call to the service were found to be actually associated with poorer outcomes, which they had not known before. So this information can help with improving the algorithms and the decision support tools for the future. But that's what they found in the PRIEST study in the 111 calls.
And do you know, having the study having reported its findings, were any changes made to the algorithms to correct either the underestimate or overestimate?
I don't know, but I can't imagine that the timeliness would have worked for that, but I'm not sure.
Whilst we've got this page up on screen, I think at your paragraph 69, you make reference to false positives and false negatives, certainly lower down the page. Just help us with what you mean by that, please.
So false positive is when somebody is allocated a high response when they didn't need it. So they was thought to be in an immediate and life-threatening situation when they weren't. Call that a false positive. Whilst that is going to put pressure on the whole system, and you don't want to over-respond to calls, it's not putting an individual in danger. Mm-hmm. But the false negative is putting an individual in danger, because it's when a patient who should have had a high priority is given a low priority. And so it's a false negative. And that is happens more rarely. It doesn't happen as often as the false positives, but it does happen, and that's a situation which is dangerous or lacking safety for the patient.
Yeah. I think you're saying there, though, that in fact no triage tool always gets it perfectly right all of the time. You say there will always be false positives and false negatives, but you will reduce them to what is called an acceptably low level, where the test is worth it despite the occasional errors.
Yes, and that is actually a decision. That is a sort of policy decision, or a clinical policy decision for the service as to the trade-off, really, between sending to when a patient doesn't need that level of response, and or not doing that, but occasionally missing someone that does. Just to say that, to remind everybody, really, that this is done on the basis of information given over the phone by non-clinical people, members of the public calling, with information about maybe they're in a very highly stressed situation, and it's not an easy job to assign that priority. But yeah, where the acceptable levels are is it's not something I can comment on, really.
You do make the point in paragraph 69, though, that results are not presented by ethnicity, which is seldom coded in the ambulance call centre and often missing on the scene. Can you help with why there's no coding, either at the call centre or indeed on the scene, for ethnicity?
So we're actually doing a study about this right now, and so this is why we know this in more detail. But I think it's to present ethnicity, to get ethnicity data, the question has to be asked.
Yeah.
And in the context of a 999 call, one could imagine that that's not the priority to ask. They're looking, the call takers are looking for the priority of the call and the name and address. Where do we need to send the ambulance? And other questions are not generally asked. Whether it should be is another matter, but that is the current situation, and I think it's understandable. But on scene, when patients are attended by ambulance crews, there's much more information filled out, and there's an opportunity then, unless the patient is in a critical situation or unconscious, there's generally the opportunity to ask for ethnicity. But we have found that ethnicity data is very, very often missing. And where, for instance, we're doing a study now where an ambulance service told us that we have ethnicity on 80%, 84% or something of our patients. But when we came to look at it, they were the white British patients that were marked down with their ethnicity. And the missing ethnicity, there were very, very few other ethnic groups coded. So we assume other ethnic groups are going into the non-coded. We can only assume that it's a reluctance on the part of the ambulance crew to ask those questions in the emergency situation.
Do you think it would be helpful? Certainly, let's take the call centre out of it, because I take your point about it may be urgent and there are different priorities. But do you think it would be helpful if in future there were, at least on the scene, ethnicity data recorded?
Yes.
Can I then just bring this section to a conclusion? And I think you say at your paragraph 78 that clearly 999 and 111 services were overwhelmed at times with great degree of variation depending on which service it was. Are you able to help though with whether 111 effectively reduced the pressure on the ambulance services and the emergency departments, as was the aim, by telling people to call 111?
I actually think it's impossible to tell that, because when NHS Direct and then 111 were first introduced, that was the aim of the services, and actually seemed to generate new demand. And so the extent to which people who called 111 would otherwise have called 999, we just don't know.
Maddie, would that be a convenient moment?
Yes, certainly. I shall return at 3:10.
All rise.
Kerry.
Thank you, my lady. Professor Snooks, can I ask you, please, about two other services that were set up in the pandemic to support NHS 111? We've looked at, obviously, the real spike in the number of people calling them and the impact that had, but I think it's right that you set out in your report that there was something called the COVID Response Service that was set up, and then another service called the COVID-19 Clinical Assessment Service. Can you help me with both of those? What were they trying to do and did they achieve it?
So I'm less familiar with these services. I know that they varied across the UK, so there were different local responses and these services set up. But in terms of how they all fitted together, this is not my area of expertise.
Fine. I think you did include in your report, though, some of the call volumes that went to both the COVID response service and indeed the clinical assessment service. And correct me if I'm wrong, is this people that are ringing 111 and then are diverted again to one or other of these two services? Is that the aim?
Yes, I also believed 999 were diverted to these services. I'm not sure if I'm right on that.
All right, okay. I think, can we look on screen at 474-285_21? CRS, I think the COVID response service was set up in March 2020, and the CCAS, the clinical assessment service, was only started in April, which is why there's a zero in that column. It might be easier for Professor to look on the screen if that helps you.
Yeah, no, I was looking at the purpose still. Sorry.
Ah, thank you. Feel free to jump in if there's anything that you want to add, but we can see for those people that ended up being diverted to the CRS in March 2020, quite a large number there, 851,000 calls offered, answered 779 of those, abandoned 38,000. The abandonment rate was 4.5%. And as we can see, CCAS wasn't up and running then. There's quite a large volume of calls going through CRS in March, April and May of 2020. And I think, did it CRS operate at different times, which is why we've got periods where there's no data?
As I said, I'm sorry, I'm less familiar with this, service.
Okay. I think it just gives us an overview, really, though, of the number of people trying to ring and find out more advice and seek assistance in relation to COVID calls. And if we just look down the CCAS calls, they were, I think, a remote clinical review of patients that then directed them on to the most appropriate care. And you can see there, 62,000 people ringing that in May of 2020, and then diminishing numbers and varying in numbers depending on where we were in the peaks and the waves of the pandemic. In your report, you make the observation that those people working in the emergency operations centres providing the immediate response to 999, they were trained but not clinically qualified. Is that correct?
Yes.
Ambulance services increased the number of clinical advisors to support the increase in the volume, and they diverted clinically qualified staff from other roles to help in that response. Yes. And you say in the Welsh Ambulance Service, many clinical advisors switched to working from home, leading to reported increased levels of autonomy, but some concerns about clinical supervision and support. Are you able to expand on that at all, Professor?
Which paragraph?
Paragraph 53, your page 20. If it helps you, we're going to put it up on the screen.
So this is taken from this paper by Brady and Harry. I don't think I can further comment on that.
Okay. And so you wouldn't be able to help with what clinical supervision was provided to the workers at home or anything of that nature? All right,
No.
then I won't.
Or how it differed from what they would get if they were in the call centre.
That was the other question I was going to ask.
Sorry.
But I fear you won't be able to help. All right. Perhaps a topic that you will be able to help us with, Professor, is the trends in ambulance responses and handovers. And it starts at your paragraph 79. And clearly you say response times were variable at the start of the pandemic. People will be familiar with delays to ambulance response times even outside of pandemic times. But you say, for example, it might be easiest to look at figure 6 on page 26. So category 2 calls in England, not the most urgent, but the next one down, it would include people having a stroke and with chest pains. This is the mean ambulance response times in England. And we can see there in January 19, the position. And the dotted line running across the bottom there, I think is the line at 18 minutes, which is the target response time for a category 2
in England.
In England. So you should get an ambulance with you in 18 minutes, 90% of calls to be responded to within 40 minutes. And then if we track across, we can see that in March 2020, in London, which is the black line, response times jump to over an hour.
Yeah.
Go on again, a dip in the summer, a rise again then in autumn and winter into 2021. And then, Professor, we get a significant increase as we go through 2021 into 2022, and albeit outside of our relevant period, a spike of over 2 hours, 30 minutes response time by the time we get to November, December of January 2022. Now, I'll come to the end, but we can see there a rise throughout the pandemic, albeit perhaps less severe waves. Can you help with why it was rising throughout 2021 and 2022?
So they're complex. So it's important to remember these are not the Category 1 calls, which are the immediately life-threatening calls, which are prioritised really at the expense of Category 2 and other calls. It's very related to demand. So at peak times of call demand, then we're seeing these higher response times. They're very variable, so they're not affecting everywhere at the same time. But it's complex because with the increased volume and also the increased complexity of calls with COVID-19, the job cycle time, which is the time from when the 999 call is made till when that vehicle is free again, really increased dramatically. And we saw ambulances queuing outside hospitals more than we'd seen before, which is then impacting further on the availability of ambulances to respond to the next calls. So this is a complex picture of demand and coping with that demand by the services. So it's it is demand, but it's more than that. And the availability of staff as well, because of the high sickness levels. So all these things are coming together to mean that at times ambulance services, I would say, were overwhelmed by their demand.
And in fact, we can see there a shift from London being the spike at the beginning of March 2020, and if we go to the spike in March of 2022, it's now the southwest of England that's got the worst response time, and indeed it remained in the southwest of England by the time we got to the end of 2022.
Well, you can see there in that spike, London Ambulance Service, the spike for the London Ambulance Service is higher than it was in the first.
Yeah.
So, yes, it was a generalised, but it didn't affect everyone at the same time.
It's nonetheless, though, a long wait from the 18 minutes that should have happened at the beginning of the pandemic to waiting over 2 hours plus for a Category 2 response. All right, and then let's just look at Wales briefly. There, can I have up on screen figure 7? These are amber calls, which again is not immediately life-threatening, as I understand it. Is that correct?
Yes. I think it's equivalent to Category 2 for England.
I think are you aware that amber was subdivided into amber 1 life-threatening and amber 2 serious, but not immediately life-threatening? Were you aware of that?
Yes.
Right. And in Wales, here are the health board's response times, and we can see in 2020 they start to rise significantly as we go through the pandemic, and again a significant spike as you go through again towards the end of 22 and into the beginning of 2023.
Yep.
I think there's no set response time, is that correct for
That's
amber?
right.
Right, so there's no baseline of 18 minutes or the equivalent in Wales.
Not for they only have the 8-minute response time for the
Category.
immediately life-threatening
Yeah,
ones.
life-threatening, thank you. But again, nonetheless, significant waits by the time you get into 2021 and 2022 if you are in the amber category, including up to nearly 4 hours by the time you go through 2021 and 2022. And not an equivalent set of data for Scotland, but just give me one moment. Data for Scotland, I think, shows again that there was a significant rise in the average turnaround time from 30 minutes pre-pandemic to nearly an hour at the end of June 2022. So not in the same category as England and Wales there, but a rise nonetheless. Are you able to help at all as to why there was a rise but not such a steep rise in Scotland?
Can you point me to where you saw that about the turnaround time?
Yes, it is in paragraphs 82 and 83 in your report. And I think it was in data provided by Scotland. that showed the turnaround time.
I can't see the Scottish data there, but I just wanted to say that turnaround time is not the same as the job cycle time that I referred to earlier. Turnaround time is the time specifically at hospital to offload the patient,
Fine.
pass on clinical handover, and then the ambulance being free, for which there are national standards of 15 minutes. And the turnaround time that you're talking about now is that handover and handover delay, which is what is referred to in paragraphs 82 and 83.
So we don't always have the equivalent data in terms of the length of time you wait for an ambulance. In Scotland, though, we do have the length of time at hospital. Is that the...
Well, I don't think so, because 82 and 83 are not about Scotland.
Right, have a look on the screen, because we've called it up onto the screen now in front of you. And we've got the turnaround times for Scotland, where we can see it rises quite significantly as we go through 2019, 2020, and throughout then our relevant period.
As it did across the UK, I believe.
All right.
But yes, the individual data sets and definitions are not exactly the same, so it's quite confusing to try to pull this data together in a consistent manner.
Thank you. That's all I wanted to ask in relation to that aspect. And Professor, if it helps you, although you've set out in your report some of the impacts that the pandemic had on the ambulance service workforce, we've actually heard some evidence from other witnesses about that, so I won't ask you about it. Can I change topic completely, please, and deal with parts of your report in relation to shielding? And I'd like to please start at the end, as it were. And before I do so, is it right, Professor, that you in fact were on the shielding patient list yourself?
Yes, that's right.
May I ask you at the outset, and I don't mean this impolitely, has your personal experience of being on the shielded patient list affected anything that you've included in your expert report?
I think being on the shielded patient list myself only made me really keen to gather some evidence about the effectiveness of shielding. So I was very committed to being able to carry out some research and evaluation in this area, but not in terms of the interpretation and the results provided.
Thank you very much. All right. And can I put up on screen, please, page 52 of your statement, which is where you deal with your summary. All right, now you make the point that shielding was implemented and evaluated in the context of almost simultaneous introduction of general lockdown. And therefore we have to keep that in mind when we look at some of your conclusions. And you say this at paragraph 147. There is no evidence of overall reductions in COVID-19 infection associated with shielding, except in a subgroup of rheumatoid arthritis. There is evidence that hospital-acquired infection was higher in the shielded group, as the mechanism for protecting clinically extremely vulnerable people from serious harm or death during the pandemic is to avoid infection. These results cast doubt on the effectiveness of the shielding policy. And in coming to that conclusion, you make the point there is little high-quality evidence on the impact of shielding on mortality, but those researchers that have investigated this have not found consistent or sustained effects. And then you set out various other things. Now, I just want to ask you, given that you accept there is little high-quality evidence on the impact of shielding on mortality, and given that we've got to bring into it caveats that we're in lockdown generally across the entire population, and I think you make the point there is no clear controlled group to say, well, if you hadn't shielded, this what would have happened. Why is it that you come to the view that the shielding policy was perhaps not as effective as it might otherwise have been?
Because the shielding was introduced against the background of generalised lockdown, and that's just context. That's not a caveat, really. That's just context. Shielding was not evaluated as a standalone policy because it was introduced almost at the same time as lockdown. So and nobody could look at shielding outside of lockdown. That was the background. Because shielding was introduced as a public health policy across the UK at one time, there was no possibility of carrying out any kind of randomised trial or experimental research to see whether it was effective or not. There was no evidence of effectiveness that it was based on. It was introduced only in the UK and in Republic of Ireland, nowhere else in the world. So in that context, we've looked at the best quality evidence that was produced through several high quality research studies, but they were not randomized controlled trials, which were impossible. So my view then is that you make the best of the evidence that you have. And several of these studies constructed the best control group or comparator group that was possible by, for instance, constructing a similarly vulnerable group. They couldn't be exactly matched because the shielding policy included entire clinical codes. So you couldn't have matches for those clinical codes. And so every study that has used some kind of propensity matching, which is sort of trying to identify other people that were equally vulnerable, none of those studies, including one that I led, was able to do that perfectly. Nevertheless, the comparisons between people shielding, the best comparator group available, and then the general population, several studies have come to the same conclusions. There may have been isolated, short-term, regional improvements in one aspect or another, but overall no consistent evidence of an impact on infection rates or COVID-related mortality, which is what shielding was trying to achieve.
May I understand this, though? Would you not expect a higher rate of mortality in people because they're CEV? It's their underlying comorbidities that make them more at risk. So it's not surprising, is it, therefore, that more of them died?
Well, so most studies have found a higher mortality rate, which I would expect. But a higher COVID-19 related mortality rate, one would have hoped not to see. And in particular, there is a much higher rate of hospital-acquired infection amongst people in the shielding group to their comparators, which I think this is the interpretation that we've come to, that that's the reason it couldn't work. Whilst people might have been shielding from their neighbours, their friends, their families and so on, they were having such a high contact with hospital staff and healthcare practitioners that whilst healthcare associated infection was not under control, shielding didn't seem to be able to, was not able to be effective.
So does your conclusion come to this, that whilst hospital-acquired infection rates were high, then shielding itself could not have been effective as a policy?
Yes, as a public policy. Not on an individual level. I want to make this really clear because I know this is really a sensitive subject, that this is not saying that individuals should not have isolated at all. This is saying as a public health policy, should this have been, was there evidence, should this have been produced, should it be introduced in a future pandemic? And my conclusion from all this research is that whilst hospital-acquired infection is so high, then shielding as it was introduced last time simply couldn't be effective.
What about those shielders who didn't need to attend hospital, though presumably there's no evidence about what the effect of the policy had on people who weren't going into hospital for appointments and scans and the like?
I think there were very few people in the shielding group that were not having contact with healthcare professionals, and the hospitalisation rates were much higher amongst shielded people than the other groups. But there may have been pockets of people. We did look in subgroups, and we didn't find any evidence within those subgroups, of clinical subgroups, of reduced infections and reduced COVID-related mortality. We were looking, but we didn't find it. And if ours was the only study that did that, that's one thing, but ours was not an outlier. Each of the studies we looked at, the large-scale studies, was coming up with the same conclusions.
Of course, if the people who shielded did not suffer hospital-acquired infection, is there anything to suggest that shielding policy wasn't effective for those people?
This would require further look at the data, which could be done, hasn't been. As soon as you start separating out groups, it becomes very complicated because then you're looking at, well, who's our comparator group? And is it that, so in the other vulnerable people group who are comparators, do we then take out the people there that were went into hospital? As soon as you start doing that subdivision, the comparisons become less and less credible and valid. So we can look at that more, but that hasn't been published to date.
I'm asked to ask a number of questions of you on this topic. And I suppose one of the matters I think you are aware of is we asked Professor Whitty about your views.
Yes.
And he made the observation that you'd set out the various studies in the way that you have in your report, but essentially said he wouldn't go as far as you in interpreting them in this way. He said that he is not excluding the possibility that you're right, but that certainly wasn't the intention. And it's certainly, he says, there's effectively an absence of evidence one way or the other doesn't mean that the shielding policy did not work. Can I ask for your views on that, please, Professor?
Yeah. I think this comes down to whether in a situation where you cannot carry out a randomised controlled trial, which is generally seen as the gold standard of evidence, in that situation, any other study is going to be have its caveats and its limitations. But I don't think it's a sort of, do you throw the baby out with the bathwater? We still have to try to gather the evidence that we can and interpret it to the best of our ability. So these are very large-scale studies. The study that I led was the whole population of Wales, 130,000 shielding people and 130,000 comparators. So these are not small studies. These are over considerable time as well. And so my response to that would be we are taking the best studies we can with the best evidence we can and making the most of that. For instance, the Medical Research Council funded our study. It was £1 million to do that study. I wouldn't like to sit here and say, well, we didn't find anything out. We found what we found, which was no evidence of an improvement in COVID-related infections and higher COVID-related mortality. And much higher hospital-acquired infection. And so I feel duty-bound to report that and make the best of that evidence that I can. But I understand that others will criticise that.
We'll have a different view.
Yes.
I ask you, though, because actually when it comes to your ultimate conclusions in your report, you said we cannot recommend that shielding is introduced in a future pandemic as the best current evidence does not show that it was effective in terms of reduced infections or COVID-19 related mortality. And you say that in a future pandemic, we recommend attention needs to be paid to healthcare transmission as a priority because shielding cannot work while infection rates from hospital and other healthcare contacts are high. And I'm going to ask you, do you think that's overstating it? And it might be that it might not work whilst infection rates are high, because clearly there are plenty of people who didn't go into hospital who were shielding.
I don't believe it's overstating. I've considered this and reflected and considered because I've been challenged several times during the course of putting this report together on this. And have come back to the same conclusion from our research and from the research that others have carried out in this area. That's the conclusion and the recommendation. And that's also taking into account that the cost to the public purse and the alternatives that have not been able to be done, and also the restrictive nature of shielding and the adverse effects on people's psychological well-being. So it's not like there's no cost to shielding. There are both financial and costs in terms of harms to patients through the shielding and protective effects, both. And it's trying to get a balance of that out. But whilst it didn't, the whole point was to reduce infection rates. And if it couldn't achieve that, whether it be through the overall infection or the hospital-acquired infection, then it doesn't feel to me that we could recommend it in a future pandemic, that the priority should be on reducing hospital-acquired infections. And it is absolutely not to say that individuals should not have self-isolated. This is not what we're saying here. We're saying as a public health policy, did this work?
Hence why you say you've come to the conclusion that you have. Can I ask you about perhaps a more positive aspect of the shielding programme? I think you said that if you were on the shielding programme, you're more likely to be vaccinated.
Yes.
And was that not a positive benefit,
Yes.
particularly to those later, once vaccines were available and being rolled out?
Absolutely. It wasn't the purpose of shielding,
No.
but it provided a really good vehicle for rolling out vaccinations to the most vulnerable people first. And we did find both a higher proportion of people vaccinated than our matched group and much higher than the general population. And also they got vaccinated earlier.
Professor, just would you give me one moment? I just want to check that I have covered all of the questions I need to ask you in relation to the shielding programme. Only this, and I suspect we know the answer, but I'm asked to ask whether it's more accurate and nuanced to say that the effectiveness of shielding would have been better enhanced by better controlling rates of nosocomial infection, rather than saying we shouldn't have the programme in the future at all. What do you say to that?
Well, we don't know the answer to that.
Well, Lady, they're all the questions that I have. There are a number of core participant questions, though, for the Professor.
And I think we begin with Mr. Rowett.
Yes.
Over that way, Professor.
Good afternoon, Professor Snooks. My name's Bilal Rawat, and I'm here on behalf of the United Kingdom Health Security Agency, or UKSA as it's been described during the course of the inquiry. I've got a number of questions for you which relate to some of the studies on shielding that you've cited in your report for this inquiry. My time, as you may find out, as I may find out, is limited, so I'd be grateful if you can keep your answers relatively short. My first question relates to the 2021 paper by Janney and others, which is the Glasgow study, I think. Can you confirm that study considered 3 different groups with 3 different levels of risk for catching COVID and for dying if they did catch it?
Yes.
And would you agree, therefore, that the Janney study did not account for all confounding factors, an obvious one being the levels of comorbidity, because the 3 groups in the study had, by definition, 3 different risk profiles?
Sorry, I don't think I'm understanding the question. I mean, I don't think one can ever account for all confounding factors. But the comorbidities would have been indicative of the risk category they were put into. So in a way, they were considered, I believe. Am I answering? I'm not sure if I'm answering your question.
I'll take your answer so that I can move on to my next question. And I'll move on to the Liverpool study, which was the one by Philippe Barnett and others. That was a study, wasn't it, where there was an attempt to match a comparator group. Is that right?
I believe so.
Because I think from our reading of, of your report and the study, it compared a shielded and non-shielded group matched, for example, for age, sex, diagnosis with a long-term condition. So there was an effort to find a comparator group, wasn't there?
In the Liverpool study?
Yes.
Yes.
The authors of that study found, and I quote, shielding was associated with a 34% reduction in the risk of dying compared with a propensity-matched non-shielded group. Would you agree that this was a reasonable conclusion for these experts to reach based on the data available to them?
So my reading of that study was that there was, at one point in time, a reduced risk of mortality, but then over a longer period, that reduced risk of mortality disappeared. It's quite confusing to understand their results. I agree, but that's what I understand from that study, that it was a short-lived, and it was also in just that one area, in one region, but it was a short-lived reduction in mortality, but then over the longer period, it disappeared.
Thank you. If I move on, I'm going back to a point that was canvassed with you by counsel to the inquiry. And my question is this. Given that those shielding, A, could attend hospital appointments, B, were likely to have to attend hospital more frequently than those who were not shielding, and C, were, by virtue of pre-existing factors, more at risk of acquiring an infection when attending hospital. Would you agree that the incidence of hospital-acquired infection in the shielding group is not a viable measure of the efficacy of a programme that was intended to reduce the exposure of the most vulnerable to community transmission?
I think that's fairly nuanced. I think actually the point is that shielding was intended, my understanding is shielding was intended to reduce COVID infections overall in the clinically extremely vulnerable. Where they got it doesn't feel like it's really the point. But you would hope that, I would have hoped that hospital-acquired infection would be, I mean, it's dreadfully sad. It's all sad, but it's dreadfully sad when the infection is picked up in hospital. So you're asking me whether it's an unfair comparison because they had to go to hospital. Is that right?
Well, my question is directed to whether the use of the incidence of hospital-acquired infection as a measure of a programme that was intended to reduce community transmission.
Okay. I guess that's a fair point. We were looking at that point. This was not our primary outcome. Our primary outcome was infection and COVID-related mortality. The hospital-acquired infection was an attempt to understand the mechanism.
Thank you for that. Can I move on to my last question for you? It's this, and it picks up on a point that was put to you about Professor Whitty's views on your report. Would you agree that it is near impossible to conduct a meaningful analysis of the shielding programme, not only because of the limitations in relation to a comparator group, but also because it's difficult to disentangle shielding policy during this pandemic from wider societal measures such as social distancing and lockdown?
Sure, it makes it more challenging. But our study and other studies did not, I said this at the beginning, did not evaluate shielding. It was not a standalone initiative. In the study that we looked at in Wales, we did send out questionnaires to people in the shielded group and in the also vulnerable matched control group. And there was a distinct difference in terms of behaviours. So people in the shielded group, both originally and 1 year later, were still isolating a lot more than people were reporting that they were self-isolating, a lot more than the people in the matched control group. So and for people who were affected by shielding, I think they will understand that shielding was a level above general lockdown. So general lockdown was, of course, restrictive to people, but shielding was on another level. So to be asked or instructed, however you saw those initial letters, to take one's meals separately from one's family for the next 12 weeks, to not be in a room with family members during that next 12 weeks. It was a step much higher than general lockdown. So I think, well, as a researcher and as a health services researcher, it's absolutely it's my obligation to try to understand how well that worked, and is that something that should be done again?
Professor Snooks, thank you for that. My lady, those are our questions.
Thank you very much indeed. Ms Mitchell, that away.
Professor Snooks, I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved, and I'd like to ask you some questions on a matter which hasn't been touched on in any great detail so far, and I hope you're able to assist me. If it's not within your area of expertise, please just obviously let us know. The inquiry has heard a lot about the precautionary principle, and perhaps it's something that seems easy to say and quite a few people disagree with what it is, but going on the basis that using the precautionary principle is, in layman's terms, better safe than sorry, would, in your opinion, the availability of powered respirator hoods have helped reduce infection rates in paramedics?
So I'm very sorry, but it is outside my area of expertise. I'm not able to answer.
I did preface my question as I wondered, having reflected whether or not that was in your area, and I have no further questions, my lady.
I'm sorry I couldn't answer that.
No problem. Thank you.
Thank you very much, Ms Mitchell. Right, who's next? Pua. Behind the pillar.
Professor Snooks, good afternoon. I ask questions on behalf of COVID-bereaved families for Justice Cymru, who are a group of bereaved families based in Wales. Can I ask you a question about 999 and 999 in Wales? In a statement to this inquiry from Jason Killens, who's the Chief Executive of the Welsh Ambulance Service, the NHS Trust, he describes a system that existed before the rollout of the intelligent routing platform in November 2022, with those that made calls to 999 who were based on the Welsh borders, particularly when they made that call on their mobile phones, were often responded to by providers in England and then would have to be retransferred to callers within the Welsh Ambulance Service NHS Trust. First of all, were you familiar, or are you familiar with that system?
I'm familiar with it broadly, but not in great detail.
All right. Well, I'll just ask you some follow-up questions on that and see if you can assist us with it. Did that system add at all delays in responding to 999 calls by having to transfer to England and back to Wales?
I would have thought it would have improved the response because they were transferred, I understand, when calls were not being able to be picked up quickly within the one service. I may be misunderstanding.
Okay. And can you explain in practical terms how call handlers were trained on when they were based on the borders? No? Okay.
I'm sorry, no, I'm not able to answer that.
Fine. Then the next topic I want to ask you about is 111 calls within Wales. And you state at paragraph 43 of your report that Welsh Government data demonstrated a similar pattern to that of England in terms, at least as I understand it, the volume of calls that took place at the start of the pandemic. But does it follow as well from your paragraph 43 that performance in Wales also reflected the performance in England?
I believe so, but I don't have the specifics of that.
Okay. And in that case, can I ask you, also again practical terms, when calls weren't answered on 111, did it go through an automated system at all, or did it just simply continue to ring? Or you don't know?
I don't know, but I don't know. This is the answer to that.
Okay.
And the term abandoned is a bit like abandoned by the caller or abandoned by the service. And I think it means it wasn't answered.
Right.
So the term abandoned is slightly not helpful there, as I think.
And my last question is just in relation to calls not being answered on the 111 system, what was the expected alternative for families who couldn't access the service? What was the advice, or what were they supposed to do in that situation?
Well, I don't think it was expected that 111 wouldn't answer their calls, but then they would be falling back on the other providers of unscheduled care, be it their out-of-hours GP or in-hours, depending on the time of day, or the 999 service or the emergency department. Those would be the sources of advice available, but they were all compromised at the same time.
Yes, thank you. The remainder of my questions have already been answered in the course of your evidence, so I'm grateful.
Just before you sit down, Mr. Power, can I just pursue a matter that Mr. Power was asking you about? I'm afraid I didn't appreciate this until Mr. Power's questions. If you're on the Welsh border and you basically need a response from the Welsh Ambulance Service, but you're using a mobile phone, so your area can't be tracked, which I think is the point of the using the mobile phone, Mr. Power, is that right?
Yes, as I understood it, it was the call centre pylons or whatever, pick it up.
Okay.
Yeah. So basically, it's picking up somebody who's on the English-Welsh border, but can't actually pick up that they live in Cardiff or wherever. I'm just thinking about so supposing it's rerouted to an English call handler. Their first questions aren't going to be where do you live, are they? They're going to be...
Are we 999 or 999? Yes.
999.
Their first questions are, is the patient conscious breathing?
Yeah, exactly.
Yeah.
So it must cause a delay, mustn't it, if the call handler has to go through all the process of what's your categorisation triage process before they even get to the address and the postcode?
I don't think necessarily, because that call prioritisation could be passed back to the Welsh Ambulance Service. They wouldn't have to go through it again. But I'm sorry, I misunderstood at the time, because there are also systems for when services are at over capacity and they can't answer their calls for neighbouring services to be handling those calls, and that's what I thought you were referring to at the beginning. So this is a different issue. I don't think in principle that should lead to a large delay, but at a time when services were so stretched, I can't answer if it actually did in practice.
So did I get the wrong principle, Mr. Pearl?
No. Can I just ask one further question arising from that then? So there's a delay initially when calling 999 to get through to an operator. They're just
very short.
So the operator in England then is ringing on the same system, or can they transfer directly to a...
Yeah, I don't know about the telephony arrangements they have in place. But so when you call 999 first, you get through to the generic responder asking fire, police, ambulance. When you get through to the ambulance service, those answering the phone delays are very short, and I believe remained very short during this period. And so then the call prioritisation would happen, and then it would get transferred back. In principle, there shouldn't be a big delay involved in that, unless the receiving service was very stretched with its with answering and dispatching, which they were at this time. But in principle, I couldn't see that in itself should be causing a delay.
All right.
But I don't have the data to back that up.
Thank you.
Thank you very much, Mr. Wagner. Mr. Wagner's over there, Professor. Can you see him?
Good afternoon, Professor Snooks. I want to ask you first about what I come to think of as the frying pan and the fire issue.
Sorry, could you just let me know who you're speaking of?
I'm sorry, yeah. I'm speaking on behalf of clinically vulnerable families.
Thank you.
So for many clinically extremely vulnerable people, on the one hand, they were being told they needed to stay at home because they were at high risk from COVID, that community transmission point. And on the other, they knew or at least suspected that if they went to a healthcare setting for an appointment, they could be at high risk of contracting COVID because of lack of adequate protection and mitigations in those settings. Do you agree that that led to extremely difficult choices for those clinically extremely vulnerable people, perhaps including yourself, about deciding whether to attend healthcare appointments or not?
Absolutely, yes.
I want to ask you, secondly, about the end of shielding, which you haven't talked about in the oral evidence, but you refer to in your reports. So when shielding came to an end, was lifted in March 2021, other protective measures, such as mask mandates and social distancing requirements, were lifted around the same time. And at that stage, vaccines and antivirals were still not widely available. And in fact, vaccines hadn't been given out even to all of the clinically extremely vulnerable. Do you agree that the combination of those factors would have caused very significant stress and anxiety to the people who had been told up to that point they should shield?
Yeah, I think that was a very difficult time. But we did find very, very high rates of vaccination amongst shielded people at that time. But still, that would have maybe gone to some level to mitigate that. But yes, I think that was a very anxious time. And we did find that the effects of the association between being in the shielded group and strictly isolating was still much higher in that group than other vulnerable people, even a year, 15 months after the start of the pandemic in March 2020. So 15 months, 18 months later, there was a still very high level of self-isolation, self-isolating behaviours going on, and some fear of going outside.
I want to ask you about the effects of the shielding programme. I'm trying to distinguish it slightly from the sort of, if I put it like this, a sort of brute focus on mortality as the outcome. And just on a couple of positive effects, and just see whether you agree or not. Firstly, shielding it functioned as a passport which gave access to various forms of support.
Yeah.
So entitlement to deliveries at home of food parcels, priority access to supermarkets, home deliveries of prescription medication, and very importantly, statutory sick pay for those not eligible for furlough. Do you agree that just in terms of helping people on an individual basis protect themselves in the community, do you agree that was a positive aspect of the scheme?
Yes, absolutely. And I also think that in considering a future, although shielding as it was implemented during this pandemic may not be appropriate or we didn't find it to be effective in terms of the, as you say, the brute outcomes. But I do believe that there should be some consideration given to how people who are maybe eligible or need or wish to self-isolate, how they can do that. Because taking away shielding would be taking away all those benefits as well, and I'm very aware of that.
Yeah. And secondly, the ability to communicate and for members of the public to readily understand, so for example, an employer, that those shielding had an urgent and legitimate need to reduce their risks, quite different to the other population, the general public. Do you agree that educational aspect, communication aspect was a positive effect?
I think it was, but I also think that there were people that were not categorised as clinically extremely vulnerable who then kind of missed out on that. And some of those people felt that they should have been in the shielding group. So it was, in some ways, almost an arbitrary cut-off between shielding and, well, clinically extremely vulnerable and clinically vulnerable.
Well, that just brings me neatly onto the final question I have for you, which is about who got in and who didn't.
Yeah.
So obviously clinically vulnerable people, and when I speak about clinically vulnerable, I'm excluding clinically extremely vulnerable just for now.
Yeah.
So the people who wouldn't have been told to shield,
Yeah.
but they were still at a higher risk of dying from COVID, weren't they, by definition, and having bad effects from COVID. Is that fair?
I think so, yes.
Would you agree that more learning is required for a future pandemic to think through how better to protect those individuals who were given none of the protections that clinically and extremely vulnerable people were? And perhaps there could be more of a spectrum.
Yeah, I think that could be considered, definitely, yeah. And as Ms. Carey had said earlier, perhaps look in more detail of a secondary analysis of some of the data of some of the studies that have already come out to find these pockets, if those pockets exist, of people that actually benefited from shielding, for instance, or didn't, to help contribute to that formulation of policy for the future.
Thank you. Those are my questions.
Thank you very much, Mr. Wagner. Mr. Weatherby.
Thank you. Professor Snooks, just one topic from me, and I ask questions on behalf of the COVID Bereaved Families for Justice UK group. And it's simply the extent to which people with different characteristics, the needs of people with different characteristics, whether they were sufficiently and adequately catered for by the 111 and 999 services. So you were earlier taken to paragraph 78 of your report, where your key points were that the services of 111 and 999 were at times overwhelmed. And you then go on to say that existing inequalities may have been exacerbated by those factors. Firstly, in terms of ethnicity, you then indicate, as you indicated, Ms. Carey, before, that there's a lack of data.
Yes, there's a lack of coding.
Yes. Now, you've already helpfully given evidence about the difficulties of collecting data in an emergency situation. But without collecting data, then, of course, first of all, we don't know. And secondly, we can't put it right if we don't know.
Yes, exactly.
Something has to be done.
Yes, yes. So we are currently doing a study exactly on this in injuries. And this is where we found that there is no data in ambulance control about the ethnic, I was going to say case mix, but the ethnic profile of the 999 callers. But they can be linked. So if you can link those callers to other data sets, then ethnicity is available.
Yes.
So this can be done,
Yes.
but it isn't routinely done at the moment.
No. So that's again, that's a call for optimism there, that work it is in fact being addressed.
To
it's
some
something
extent,
that
but it
wasn't
needs more.
addressed.
Yes, it does need more attention, because that work it's been partially done ad hoc here and there, but it's not being done systemically.
Sure. And just to take this point a little bit further, paragraph 73, you refer to the Healthcare Safety Investigations Branch 2022 report on the 111 service. And part of that, you note that they raised questions rather than conclusions about the efficacy of the service, about a number of matters, but including language difficulties. So that would include the potential problems with people whose first language wasn't English. And again, this is an area, there's a lack of data, is that right?
Absolutely. I don't think there's any data on this at all. So this would have to be the subject in the first place of actually funded research, commissioned research to look at this.
So that should happen.
You cannot get it from routine, yes, you can't get that from routine information.
And from family members that we represent, we know that on occasion, questions were asked of them about them or their loved ones, which assumed that they were white.
Right.
For example, had lips turned blue or skin colour turned blue. Again, this may indicate a wrong assumption being put forward by call handlers or the algorithms. And would you agree that there needs to be work done to identify those problems and to rectify them if
Absolutely,
they are?
yes. I would definitely support that.
Yeah, okay. Same point, but moving away from ethnicity. At paragraph 73, you highlight the fact that the algorithms didn't take sufficient account of comorbidities. And can you help us with that? That I think that what you're driving at there is that because there was insufficient account of taken of comorbidities, then it was less efficient to people being signposted to what they needed or emergency treatment being provided.
Yes, we're quoting from this study by Rick Body, I believe. And so this is their conclusions. I'm quoting them, but I would support that.
You'd support that. So again, this is a deficit which needs to be looked at and addressed.
Yes.
Can I take that one stage further? Would you agree that not just the algorithms, but perhaps call handler training needs to be improved in terms of taking account of people with comorbidities, or perhaps with people who have neurodiversity?
Yes.
Yes, thank you very much, Professor.
Thank you, Mr. Weatherby. Professor, that concludes, I think, all the questions that we have for you. Thank you for your help, and I hope that the recovery continues apace.
Thank you very much.
I hope you haven't been too uncomfortable in there.
No, thank you.
Very well. 10 o'clock tomorrow, please.
All rise.